To establish a district-wide project, we had to strengthen many key processes. For instance, we had to begin with developing a mechanism for effective coordination and meaningful supervision. This meant that from the district coordinator to the link worker, an average of 4 to 5 days a month is spent in strengthening processes. Between the link workers, supervisors, taluk coordinators and district coordinators, the project ensured that they consulted and exchanged with each other as regularly as possible. They would conduct fortnightly meetings at the cluster level and monthly meetings at the taluk level to review activities and processes. This would ensure that every component was being supported. There was cross-learning that was happening and new ideas were getting adapted. At the fortnightly cluster meeting, they would review the delivery of programs, plan future activities such as referrals, condom distribution, STI services, and mobilizing positive people to go to services and address emerging needs of the community from the link workers. None of this was easy to accomplish. In the initial phase, some of the basic things like finding the right place for a cluster meeting itself was a challenge. We had to make sure that the process is done and taken in the right spirit, because we did not want link workers, especially the women link workers who belong to the less privileged community or caste groups, to get discouraged or demoralized by it. More importantly, at the district level, the entire project, those who were working in the demonstration project, including Bagalkot Rural Demonstration Project, the Sex Work Demonstration Project and the CARE Project, would come together to review the activities. They were called the district coordination meetings. We ensured that the gaps identified in these forums were addressed through in-service training and capacity building. These training needs were also fulfilled in many ways, from day-to-day learning from supervisors to formal training by district or taluk coordinators. We were clear from the outset that we had to involve the community in the project implementation. We achieved this in a very systematic manner. When the situation needs assessment was done, we realized that while the community was not in a denial about HIV, they were not even open about it. Though they shared with us quite a bit, it was because they did not know enough of it. For the same reason, they also lacked proper coping mechanism for it and were seeking our help for the same. So one task and one opportunity that was evident to us was not only to make them aware of HIV/AIDS, but also to motivate them to develop effective coping strategies. And this we thought we could do by encouraging them to participate in these assessments, in planning and implementation and evaluation of the project, especially at the village level. To achieve this, we had to raise their confidence in the project and at the same time strengthen the credibility of the link workers. To raise their confidence in the project, we decided to do a few things. Firstly, we organized local awareness campaigns using folk art involving local resource persons and groups. This, we can tell you, was a turning point for the community as well as the project. Suddenly, the word HIV assumed a new meaning. We couldn't have achieved that using long explanation or using words. Secondly, very early in the project, many initiatives were taken to strengthen services. Like we started STI camps, we started STI clinics, and we also opened taluk level BCTC, which we call ICTC today. This demonstrated to them that we were not only just talking about HIV/AIDS or this issue, but we're also providing essential HIV prevention services. Moreover, to establish the credibility of the link worker, we developed them as local resources, as catalysts, as facilitators of the community. We deepened their knowledge, enabled them to forge linkages with decision makers, opinion leaders, service providers, and other societal leaders in the village. We found that on most occasions, they rose above the many differences on the grounds of caste, class, and gender. This non-partisan role helped the link workers to create and develop the maximum consensus on the issue among all sections of the village community. While we were involving the community in the project, we also began to build an enabling environment for the project. We did this by mainstreaming the concerns of the community and by strengthening intersectoral linkages. A significant step that we took was to set up the project office within the district hospital. This practice persists even today, and it has proved the point that public-private partnership can be forged. Soon, the then Deputy Commissioner, he took this partnership forward. During the annual planning exercise, he made this project an integral part of the joint action plan of the district. This was followed up by setting up a mechanism to ensure timely coordination. A district coordination committee was set up, which began meeting 5th of every month. And in that committee, they would plan activities, sort out disagreements, and discuss and review strategies. At these meetings, the project representatives forged strong day-to-day implementation strategies. Together, we did large district-wide campaigns and events to raise awareness and consciousness about HIV. The key message was, we are all in it together, and the district has the strategies and the will to cope with it. As we were strengthening the linkages to the project and working towards scaling it up, we had to tackle with another very important issue, addressing stigma and discrimination against people living with HIV/AIDS. Since the village's attitude to HIV-positive persons was dictated by panic and fear, the solution they gave was take them away from the village or make a sanatorium or center where they can live. Our challenge was to fight that attitude. But since we could not undermine the confidentiality of HIV-positive people and disclose their status, we decided not to form support groups at the village level, but to encourage them and form support groups at the taluk level. To begin, the first support groups met at the VCT center at the district hospital. Initially, the response was not too good. Slowly, it grew. Support groups started to spread to Jamkhandi and Mudhol. Within the village, the link workers started reaching out very discreetly to people living with HIV/AIDS, motivated them to be part of these support groups. Positive speakers were drawn from the community of people living with HIV/AIDS to address awareness rallies, educate community about HIV, life after HIV, and ways to prevent it. They also did street plays. One of the street plays was named Who is Responsible? This was done to create greater responsibility on caring for HIV-positive people. All these initial activities, they all culminated in the formation of Jeevan Jyoti, a district-level network of HIV-positive people. This was the first district-level network of positive people. Along with working with HIV-positive people, we also focused on addressing vulnerabilities and risk. In the rural context, concerns such as early marriage assume great urgency. The government was also taking steps to stop mass minor marriages. For the link workers and the HIV-positive people, since they saw the link between child marriage and HIV, they decided to address this issue in a more community-centered manner. The Stepping Stones training we were conducting also addressed these structural issues and enabled us to create local action on it. Simultaneously, we spread awareness on condom use to reduce the risk to HIV. Initially, we faced some resistance and with some difficulty identified condom depot holders. In the first training, just about 24 persons turned up for the training. But in contrast, we did the same training again after a few months and we found 200 new condom depot holders came for the training. What was interesting was that out of them, around 65 were women condom depot holders. We also had to reach out to rural sex workers. They were highly vulnerable and we had to help Chaitanya Mahila Sangha to reach out to them. We had to win their trust and enable them to come in terms with their realities and collectively address their concerns. Finally, we had to ensure sustainability by forming village health committees. The village health committee is constituted of elected members, youth, women in the village. They took the responsibility of promoting an integrated healthcare approach and laid great emphasis on HIV prevention, care and support. They played a very critical role in reducing stigma and discrimination against people living with HIV and AIDS. Their focus on health compelled many of them to address the overall development of the village. Today, they are reconstituted as village health and sanitation committees. They are seen as an integral part of the rural healthcare mainstreaming that is being sought to be achieved through the National Rural Health Mission. It is clear from the above presentation that to set up a district model, we need to ensure that we bring together many strategies. Some of those strategies are: develop effective coordination and supervision mechanisms, involve the community in project implementation and monitoring, implement strategies to address risks and vulnerabilities, strengthen intersectoral linkages, build sustainability through village level governance. Each of the strategy had to be implemented in close coordination with other strategies. It was clear that every strategy or processes had to be given equal attention and emphasis, as they all helped to develop a district response that was multi-pronged, integrated and comprehensive. We will conclude now with some more exercises, questions for discussions, focus on choice of strategies and what it takes in terms of planning and perspective to mount such a comprehensive district response. Thank you.